I started foot and ankle surgery in an unusual way really, because initially I was very interested in revision hips, revision knees, and foot and ankle surgery was something that was around that I needed to do because I was taking over the practice of my mentor, Professor Klenneman, who pioneered foot and ankle surgery in this country. And it really just took over because the other people would be doing hips and knees, but not many other people were doing foot and ankle. And it just became more and more interesting the more I looked at the number of joints, the number of ligaments, the tendons, all the different parts of the foot and ankle, all the different diseases. It was a very interesting area to get myself into, and the rest is history. Some people think that foot and ankle surgery is painful. And it used to be in the old days. Many people will ask their grands about their bunion surgery and they'll say it's the most awful surgery they've ever had. And in those days, really, they used to break the bones, reset them, put them into plaster. And so you're effectively walking around for 4 or 6 weeks with a broken foot. It's completely different nowadays. We use small saws to carefully cut the bones in a very precise way. We move the bones to where we want them, and then we fix them with tiny little screws and staples and lock everything together. And it's fixed so well, we don't need to use plasters now for a lot of the forefoot and bunion surgery. And the patients really, after about the first 48 hours, they're on a much reduced analgesia, and really by about 1 week, they're on paracetamol and that's it. And the other interesting thing is that people are mobilised within about 6 hours of their surgery now. So a lot of the forefoot surgery, the bunions and the lesser toes, we are doing as day case surgery. Sports injuries in foot and ankle has come on apace in the last 10 years. The biggest development really is that of arthroscopy. With arthroscopy, which we do as a day case procedure under a general anaesthetic, I'm able to look inside the joint. I can remove prominent bits of bone, I can remove inflamed tissue. So it's not just about diagnosing what's wrong, it's actually making people better. Even if there's quite advanced arthritis in the ankle joint, you can actually remove those areas of local arthritis and drill into the bone and get new cartilage to grow there. And 80% of the time that will be successful. Sometimes when the arthritis becomes too severe, really, the only option for a sports person is to consider some kind of a fusion operation. And even that nowadays can be done using the arthroscope. So you end up with just 4 small cuts around the ankle, and a major orthopaedic procedure, i.e. a fusion of the ankle joint, can be attained with the minimum of disruption of the soft tissues. And the big advantage to us is that you've got a reduced risk of infection, but more importantly, you've got a much higher chance of it fusing first time, and that's 90%, which is a tremendous rate to achieve. You may think it's unusual that as an orthopaedic foot and ankle surgeon, I'm going to be putting a plaster on a patient, but in fact that's quite a common thing that I have to do, because when people have a major ankle fusion or major surgery around the midfoot, then you have to hold the bones closely together so they don't move. You have to support the tiny little metal plates and screws that are in there that are keeping the bones squeezed together until that bone joins itself up. There are so many exciting advances now in orthopaedics, and especially so in foot and ankle surgery. One big change for me is the way I can now use ultrasound in the outpatient department, not only to look at joints but also to enable me to give targeted local anaesthetic and steroid injections into the various joints around the foot. This lady has early degenerative change in her big toe joint, and so I'm going to be undertaking a local anaesthetic and steroid injection, but this is going to be under ultrasound control, so I can be sure that I'm going to get the fine needle into the joint, and this reduces pain for the patient and makes it more reliable. The joint is localised on the screen and the needle will be inserted using that as guidance. Other advances include how we straighten lesser toes. We used to use wires in the toes, and they're in there for about 6 weeks and then have to be removed, whereas now we can use these tiny little implants that we put in there at the time of surgery, which lock the bones together and allow them to heal up and straighten the toes without having to resort to wires. My message to anyone who has problems with their feet is give us a call at the Bone and Joint Centre. I'm sure we'll be able to help.